Good afternoon, everybody, and thank you for joining us. My name is Cheryl Fatibene. I'm the Chief Nurse Practitioner Officer at the NNCC, and on behalf of the Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn, EHR Implementation for Small and Rural Primary Care Practices. Presenting for us today will be Rebecca Freeman, who is the CNO at the Department of Health and Human Services. So the national, So everyone should have a questions format frame here up, and if you look, you can submit questions throughout the webinar today with the question pane through the control panel, or you can also raise your hand and ask questions. We will be looking at your questions throughout, and we will, depending on the number of questions, we'll probably answer them at the end. Please also look in the handout section where you will find a copy of today's handouts. The NNCC, or the National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programs to reduce health disparities and to meet people's primary care and wellness needs. Our partner in this initiative is the American Association of Nurse Practitioners, the largest full-service national professional organization for NPs of all specialties. AANP is leading the way in advocacy, continuing education, and professional development for over 76,000 members. Let me take a quick moment here to talk about the national investment taking place in quality improvement in the United States with the help of the federal government and the organizations who are presenting this content as part of Transforming Clinical Practice Initiative, which is sponsoring today's presentation. The Transforming Clinical Practice Initiative, or TCPI, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and an enrollment of 150,000 plus providers across the country. CMS funds the NNCC and the AANP to support enrollment of NPs into practice transformation networks, or PTNs, across the country, and to develop NP-specific educational material that facilitates practice transformation in advance of the upcoming payment reform changes with CMS. The NNCC and the AANP are the only nursing-focused grantee of this TCPI project. The NNCC and the AANP agree that this initiative is important to ensure that nurse practitioners receive the support they need to remain competent in a changing healthcare landscape. Nurse practitioners are the future of primary care in the United States and already provide high-quality, cost-effective care. This initiative is an opportunity for NPs to prove that by helping CMS and the broader healthcare community build on evidence based on practice transformation while preparing for value-based reimbursement. Why is CMS funding this initiative? They want to use this program to prepare clinicians across the country for payment reform. In particular, payment reform under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. Many of you now have probably heard of MACRA. It's legislation that was passed to establish Medicare's Quality Payment Program, or the QPP. Under this Quality Payment Program, there are two payment adjustment mechanisms to incentivize quality care tied to Medicare Part B payments: MIPS, or Merit-Based Incentive Plans, and APMs, or Advanced Alternative Payment Models. Most clinicians will end up associated with MIPS, or the Merit-Based Incentive Plan. MIPS involves 4 elements that clinicians need to demonstrate successfully to maximize their Medicare Part B payments. These elements are to report on quality, to report on resource use, to identify clinical practice improvement, or CQI, activities that they're engaged in their practices, and to use health IT effectively, which is what we are going to be talking about today during this presentation. Even if you think that MACRA and MIPS don't apply to you, if you can demonstrate these 4 elements in your practice, you can succeed in a value-based payment environment. The TCPI and their networks are meant to provide physicians and nurse practitioners and other clinicians with the necessary skills to execute these 4 elements of practice. At this point, I'd like to turn the presentation over to Rebecca Freeman, who will be talking to us today about EHR implementation. Rebecca?
Hi guys, thank you so much. I am really excited to be here today, so I'm going to do a super quick introduction of myself. I am actually the Chief Nursing Officer at the Office of the National Coordinator for Health IT. We're a group within HHS, and we focus on the coordination of health IT as we roll it out kind of across the land. So we did not exist until the early to mid-2000s, and when we stood up the Meaningful Use Program as part of the stimulus package in the HITECH Act, ONC came out of that, and we have done a lot of work hand in hand with CMS and some other agencies to try to move health IT forward. And having said all that, I'm kind of the Chief Nursing and Allied Health Leader in this space. So if we go to the next slide, and I'll just point out I'm not driving my own slides, so I'll just do this when we move. We're going to cover a couple of things today, and I am actually going to sign on for a part 2 of this presentation. So this is not going to be end-to-end, how do I find an EHR, put it in place, and then make it work for me kind of presentation. I'm going to cover these parts today. That is just the background on health IT and delivery system reform, how we're going to be paid in the future, what do those things have to do with each other, and how did we get here. Then I'm going to talk to you if you are in the space where you are going to be implementing an EHR, or maybe you have one in place already and it's a little bit of a pain point. We're going to talk about some things that are just the key basic components so that you feel a little better armed to go deal with the decisions you might have to make as it relates to health IT and certified EHRs in your practice. And we'll talk a little bit about interoperability and integration. And then I really want to wrap up today by showing you 2 of the ONC-specific resources that we put together to try to help you guys. So one of those is an EHR contract guide. If you find yourself owning your own practice or owning the purchasing and the implementation of health IT for your setup, wherever you're practicing, your care setting, you might be responsible for negotiating and signing a contract. And there are some obvious pitfalls in your standard vendor contract. So we put those together and we'll talk about that. And then the Health IT Playbook will actually walk through a couple of parts of that because as a follow-up to this presentation, if you have questions or you want to do some additional education, we have some modules there. So that's what we're covering today. There are certainly many, many more topics related to the functioning of your system in your practice, especially a small practice or rural healthcare practice. And if that's the case, we might pick those up in part 2. So that's our overview, and we will just dive in on background. And we'll go to the next one. Yeah, so this is as of 2015. I just want to kind of explain where we are. So where were we when we started and where are we now? So basically in 2008, we only had about 40% of office-based physicians with an EHR. And you'll notice in this slide and in a couple of other slides, I use the word physician. And I mean that literally because when this research was done, it was only done for physicians. Nurse practitioners were not included in the data set, so I can't just throw the ubiquitous provider or clinician in there. It was very specifically targeted to physicians. I will say that if anyone thinks that's a bad choice and you would like to know who you need to send email to get nurse practitioners in these data sets, please send me an email after this and I will point you in the right direction happily. So we went in 2008, we went from 42% to 87% in 2015 of office-based physicians having an EHR. The hospitals is where we really saw the explosion of growth even more. We had less than 10% in 2008. We had 84% in 2015. We're well over 90% now. So we went from no health IT to a ton of health IT. And if you guys practice in a hospital or a hospital system, you may be well aware of some of the pain points of these things having come in so quickly and not particularly in a well thought out way. Many times we just took our paper processes and replicated them in the health IT system, which is a really bad way to go. And so now we're trying to figure out how to make these work. For others of you, if you're in a small practice and you have a niche little system, or you've had the opportunity to really tweak it to your liking, you might not be in nearly as painful a space as some of our hospital and hospital clinic-based friends. Back to kind of that top bullet point, Health IT is growing by leaps and bounds because we're starting to change the conversation about how folks are paid, and Cheryl talked about this at the beginning. We are looking at alternative ways to not only be reimbursed at the baseline, but to receive incentive payments. Alternative payment models are up and coming, and really we're looking at this massive transition from episodic fee-for-service reimbursement to more of a longitudinal approach to care for value and quality, and we're going to need high efficiency levels and all of that kind of stuff. So it's a really different approach. And I put this bullet point in blue, again, on physicians because that's what is in the data. 90% of the physicians who participate in some kind of reform program, meaning like an APM, they use an electronic health record. And that's only about 40% of them total, but almost all of them use Health IT because it is really hard to optimize those kinds of care models if you don't have some kind of technology helping you out. Another very popular thing right now is population health management. It's really hard to manage the health of a population if you don't have a computer helping you. So where we are, current state, is really the hospitals and the ambulatory clinics are in pretty good shape. We have massive uptake, and now we're just working to make those systems work for the clinicians, and that's really easier said than done. Where we've still got a lot of work to do is in these community-based, non-traditional settings. This talks specifically towards nurse practitioners, and nurse practitioners are in some really wild places. So if you look at a school-based clinic, those are most often manned by a nurse practitioner. And you want to talk about a place where Health IT has not been adopted as it should. Schools are a great example. Community centers, community-based mental and behavioral health settings. So we have a lot of work to do outside of the hospital and the ambulatory clinic, and that's kind of how we've gone from nothing to a whole bunch of IT. So let's go to the next slide, and we'll just take a quick look at a picture underscoring what I was just talking about. So you can see the health system is there in the center, and that's great. They are wired. They have an interoperable within one unit to the next system, and that's good. But all of these other places, the school, the food pantry and meal service, transportation, you think about home health or a retail health clinic like a Minute Clinic, all of these areas we really have to start thinking about how we are going to pull them together to be able to not only gather data, but to share data, because we are going to be on the hook for keeping a patient healthy. And if the only data we have come from the hospital and the doctor's office, we are probably missing out on some opportunities. So I just like this picture because it's a nice big picture of what we're doing. Okay, next picture. Next slide, please. Okay, there we go. So this is my second favorite picture. Before I get into the technical of the EHR implementation, I just want to make the case to you guys, and I will probably say this multiple times. Most of the issues with your Health IT, once you get it in place, meaning the electronic health record, or maybe it's a computer attached to a device that you've brought in, lots of issues with IT have nothing to do with IT. They have to do with workflows. They have to do with behavior, accountability, a lack of standardization of practice. There are all kinds of, I call them people problems, that manifest themselves in a really bad way once you put an enterprise health record in place. So as you start to think about your journey to either fix or implement the system, just appreciate that as we're trying to move towards a new way to take care of patients and a new way to make them as healthy as we can, that right-hand side picture is really our optimal goal. The patient is in the center, everybody is equidistant around the patient, and we are all focused on the patient as we share our communication. What we have more often right now is on the left, and I would even say on the left we're a little bit optimistic, because even though everyone is in a silo, there are communication lines between them. I actually find most of the time that sometimes there is no communication path to that group in purple in the back. We'll call them the registered dietitians in the hospital. It's really hard when you're functioning in a silo and your technology isn't integrated to be on board as a part of the team. And you'll notice in that left-hand picture, the patient kind of has disappeared. I always say they're under each circle. So each little silo is working on the patient, but they're all doing that in a duplicative way. So the groups on the left could represent 10 kinds of nurses or 10 totally different disciplines. There just is not a lot of high-level collaboration happening in most places. So we have to fix those things in order for health IT to really have solid value to you. And by the way, IT will not fix these things. So if you don't have good communication and good processes and good, solid, standardized workflows in place already, putting a health IT system on top of that is not going to fix anything. It will make you crazy. So that's official from the NNCC and O. So let's move on to the next slide. Okay, so what now? Let's say that you want to select or change or optimize your health record. That's what we're going to talk about in this section, and I am not going to give you a super comprehensive overview from point A to point B so that you'll finish and know exactly what to do, but I am going to point you in the right direction of some resources and talk to you about some key pitfalls. Also on this slide, before we move forward, I do just want to make a note about data. I talked about the surveys where I keep using the word physician. I also want you to know that it's really hard sometimes to find nurse practitioners in data sets. And I just want to give a nod to incident to billing. I know that most of you probably know what that is, but in a state where you have decreased reimbursement for nurse practitioners and the reimbursement rate is higher for a physician, if the nurse practitioner sticks to a certain number of things that are allowed by the regs and they see a patient and they do the work, the physician has the ability to do incident to billing, kind of grab that work and then bill for it under the MD's name and number, so that when we go searching for data, even though the nurse practitioner may have done most of the work for that patient, the only person who shows up in the data set is the physician. So I just want, as you guys look forward and you start reading research or you start looking for workforce data or health IT use data, and you see physician, 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 just appreciate that lots of times that's coming from billing data, from CMS type data or to a private payer. But when it's allowable, physicians will frequently kind of co-opt that work and bill it out. And it's perfectly legal. That is within their right to do that because it does maximize their billing in those states where all things are not equal. But just appreciate that you may get lost in the data, and that's why numbers will sometimes not look like the way they should. So now that I've given the nod to the data and the incident to billing, let's go to the next slide and talk about implementations. So these are some very basic terms that you might hear, and I apologize to those of you who are super tech savvy. This slide will completely put you to sleep. But if you're not super tech savvy and you are out investigating for your new clinic a new system to use, these are some of the things that you're going to hear. So we all know about things in the cloud. If you have an iPhone, you can put your pictures in the cloud. If you have an Android device, you can also put your pictures in the cloud. You may also hear, especially from a sales executive who's trying to talk to you about systems that you could put in place, a client server installation. You might hear really old school, a local installation. So let me talk to you about those things so you don't get confused when you're in those conversations. The local installation at the bottom, we hardly ever see that anymore. In your computer is a hard drive where we store stuff, and a local installation just puts that software right on that hard drive, and that's where it lives. That's a really bad plan because a lightning strike, water damage, fire, anywhere that you don't have really adequate backup where that backup is stored off-site, something happens to that machine, all your data are gone. And that happened a lot way back in the day when we did everything locally. So you will rarely see this now in any care setting except as it comes to attached devices. So if you have a robot or you have some kind of physiologic monitoring machine that needs a computer to drive it, you will see things still installed locally. on that computer that runs that one little machine. And the only reason you can do that is because you're not usually storing data there, it's going somewhere else. That is not a good option, even though it's usually cheap, but it's not a good option for your electronic health records. You have to have something a little more robust. The second option in the middle is a client-server option. So I call it the magical server. To me, lots of things in technology are just magical. You push a button and it happens. So with client-server, you have one machine that's called the client, and that's the one you're working on. And there's another computer called the server, and it usually sits in a server room or a closet or hopefully somewhere that it's a little more protected. But as you type on your computer, the data are stored on the server somewhere else. That server usually has multiple hard drives, it has multiple power supplies, it is really robust, and it is set up to weather a little bit of a failure in terms of redundancy. Your normal computer is not, and that's why the servers are more expensive. And they require some maintenance. So if you're going to host your own system on your own server, there are going to be some IT components that you're going to have to own with that. So just be aware. We'll talk a little later about IT support. Last but not least, the cloud, and it's in red because for small practices, especially small rural practices, this is a really nice way to go. Frequently, these vendors offer a by-the-month paid subscription so that it's kind of economically more feasible. And then everything just routes through the internet. So you don't have to maintain your server or your backups. You log in through a browser or an icon, and you do your work, and someone else hosts all of that hardware. They do all of the IT maintenance, and all you do is just do your work. And then you can work with them to set up reports and those kinds of things. So those are really the three types of architecture. I try not to be too super technical, but these are, if you're going to reach out to a sales exec and they're going to come talk to you about their options, it's going to be one of these three options. And for a small practice, you're usually going to be looking at something in the cloud that works best for you. So we can go to the next slide. Okay, so this is a whole bunch of stuff, and I know this is going to sound shockingly familiar to you guys, as it would to any clinician. If you're trying to figure out what you need for your arena, whatever your care setting is, you're going to need to do an assessment first. And what do you need? What is not working for you? What seems broken in terms of communication and interoperability? And when you've got that assessment, you're going to prioritize all of the things that you want to get out of a system. And then you're going to make a plan. Okay, so how are you going to reach out to different vendors to get them to send you information? That is usually a request for proposal, RFP. And if you've never had to write an RFP, that's okay. You can look on the internet, and there are a million options there. So take one of those templates and just go to town on it. You've got your assessment, you plug it into the RFP, and then off you go. You send it out to the vendors. Once you've done all that, then what you have to do is select an option. From there, I would just say, please make sure you do a site visit. Part of that planning, part of the vendor walkthrough, they will come in and they will show you their systems, which is great. They will always work perfectly. They will always do exactly what you need them to do. But always make sure as you narrow it down to your top 1, 2, or 3 vendors that you go on site somewhere else and make sure you see it in action. Make sure you talk to the folks who are using it. Make sure that they like it. Ask what their customer service is like. Really important, ask if they have any clinicians on staff at that IT company, because sometimes you need help and you need to talk to a clinician. So those are all good things to know in the planning phase, and make sure you see it in person. Then you're going to make your selection, and you're going to have to install and implement it, and then you're going to test and use it, and then you're going to realize it's not working the way you wanted it to. Even if it's 90% good, it will be 10% not so good. So you're going to have a whole list of things you want to fix and optimize, and you need to prioritize those. You'll work with your vendor, get those fixed, and then you're constantly doing an assessment cycle. So it's a little bit like getting a new patient in with 3 or 4 chronic conditions, and you decide after your assessment what your plan's going to be to tackle those things, and You pick some therapy and treatment options, and then you see how they're working, and then you adjust. Use the exact same model of thinking, the same process to putting in this IT system. It's all stuff that you guys do already. It's just in technology as opposed to a patient, but it's kind of all the same process. It's all using the same section of your brain. So with that, we will move to the next very important slide, workflow. Okay, so I pull up this picture, and I use this with permission of a great set of folks where I did my very first ambulatory implementation. The top left is what everyone agreed was the workflow in the outpatient clinic. And as you can see, it is ridiculously simple. We only really talked to a couple of people to get the information we needed to try to map that workflow. And we thought, oh, this is great. And we built the system. And then we said, okay, let's turn it on. And it was a mess. It was a hot mess the first couple of days. And we were like, what the heck happened? We had the workflow, we built the system, and then we started doing some actual formal workflow assessment. And what our workflow actually ended up looking like is what's on the bottom right-hand corner. Okay, so we built a system for the top left, and we ended up with a system on the bottom right. So not only had we totally missed some things that needed to be included, but we had 5,000 communications and pathways that we didn't really even know about and we didn't account for in the computer. And as I said earlier, if you don't fix the people problems and the system problems and you plop a system on top of it, it will not fix those for you. It will make them egregiously worse. So if you're going to do this, if you're going to put a system in, even in the world's smallest practice, go online, learn how to do some formal workflow assessment, and we have some modules for that in our playbook, which I'll show you at the end of this. Do a little bit of work so that you understand how this all goes. And then more important, make sure you talk to every single member of the care team, the receptionist, the medical assistant, anyone that you have running around doing anything, because you're going to be surprised when you try to walk through just, say, the basic rooming of a patient, how many people talk to or do something with that patient that you didn't even know happened. And that's kind of how we went from top left to bottom right. But if you build your system and sign off on it based on incorrect information about your workflows, it's going to leave you in that kind of post-first assessment phase after go live. You're going to be left with a whole bunch of things that you have to fix all at once. And sometimes now you're trying to fix your workflow and you're trying to fix your IT system simultaneously. And that's a really hard lift when you're also trying to see a full complement of patients. So just be aware that workflow is really important. And you know, don't blow it off, because a lot of people do. And then they find out they actually have to do the work on the back end. So now we'll go to the next slide. This is another one. This is a really technical thing. So I always say the nerdiest of the nerdy people in health IT work on interfaces. But I'm going to try to make it really non-nerdy for you, and here it is. If you want to connect to people who are not in your office, it is going to require an interface almost 100% of the time. So if you want to connect to a community health information exchange, or you want to connect to a registry, or you send things out to LabCorp and Quest, and you want those to come back electronically into the computer, or maybe you want to talk to the hospital 2 counties over, all of those things don't just magically happen plug and play. So it's not like where you buy a printer and plug it into your computer and it says, hey, and off you go. You have to actually build those interfaces, and you'll see $ signs everywhere. Because what you need to know is when you go to negotiate with your vendor and you say, I want to connect to these 5 things, there is going to be a cost associated with building the interface to everything you want to connect to. And just be aware of that ahead of time. I'm not saying don't do it, because if you have to do this stuff back and forth with paper, you are losing efficiency. And I guarantee if you could cost it all out, you probably lose money in the long run. But a lot of people are really surprised when they implement their health IT solution, usually their EHR, and then they think they'll magically push a button and all of these data will flow from one place to the other. That's not how it happens. That is where we're trying to move magically with interoperability, but we are not there yet. We are quite a ways away. So in the meantime, you have to pay for it. Just be aware ahead of time that that's going to come rolling downhill. Okay, next slide. So Informatics Assistance. This is really when people were asking me, what are you going to talk about specific to rural and small practice and nurse practitioners? Well, I'm going to talk about the fact that if you're in a hospital with 47 informatics people and an IT staff of 150, that is a very different thing from being in a rural area where you know, your office manager might also be your HIE interface expert, or your lead nurse practitioner who drew the short straw to negotiate the health IT contract is now also the, you know, master of all upgrades. You really don't have an army of informatics help, and even if you have a little IT practice in the community, you're going to have to hire them, and that's going to be money. So you need to think about where you're going to get your assistance, because you don't have that army standing at the ready. So one thing I'll say is you can do self-reliance. You can totally educate yourself. One of the smartest providers I've ever met, really cool guy, he's up in the Northeast. He was a physician in a small physician practice, but they got really wired, and they got wired because he took himself to like a Master's of Informatics course. And he finished it, and then he got all keyed into how he could do practice and do this IT thing. Not everyone wants to be him. Frankly, some people just don't have the time to be him. But you can educate yourself a little bit. There are key components. You can find things online, and you can learn just enough that you can manage some of the basics. So please don't take the kind of head in the sand approach. The more you know, the better you can make the system. Another option is be creative. Think about volunteers from schools or communities. If you have a technical program and they have an IT program, talk to them about having an intern come in. You know, people want to go, oh my gosh, get the patient. You can have them work on things like workflows and basic technical stuff without ever putting them in front of patient information. And even so, there are ways to work around that. So just be creative. Don't hesitate to reach out to if you're near universities and they have Masters of Health Administration programs or they have nursing informatics programs, you can find, I call them super helpful but free labor, all over the place in terms of interns and students. And they are really, really technically savvy. So don't discount them as an option. Another option here is federal technical assistance. So the original meaningful use, the HITECH Act, had money for technical assistance, and we call those RECs, Regional Extension Centers. Some of you guys may have even reached out to them. We did some internal research, and we did find that nurse practitioners were much more likely to get Medicaid incentive money if they used the technical assistance from the RECs. So those are being kind of wound down because the funding is dried up for them, but MACRA has also injected some money in this technical assistance arena, $100 million over 5 years, aimed specifically at small practices in rural and health professional shortage areas. So I included the link on the PowerPoint so you can go and read about them if you want to. They are super, super helpful, and they're really well-versed in some of these federal rules and regs, which your average student coming from school is not going to be. They're just more technical. So be aware that there is technical assistance available, and that is going to be ramping up. Next slide. There we go. Okay, so last thing I'll say, you guys will hear a lot about certified health IT. So if you look at alternative payment models, most of them require certified health IT. It'll be a bullet point right there on the requirements. The ONC, my group, has very little strong regulatory authority. So we do a lot of coordination, and we do a lot of, you know, you should do this, please. We say please a lot because we don't have the ability from a regulatory or statutory standpoint to regulate things. But we do regulate the health IT certification program. So what that means is we say, you know what, if you want to be certified, Mr. Vendor, you're going to have to prove to us through testing that your system meets these minimum requirements. I've included a link if you want to read about the certification program. But just know that if you want to be reimbursed through some of these care models, you're going to have a certified health IT electronic health record. Not all of them are certified. If you think about a direct care model, and honestly, I don't know how prevalent that is in the nurse practitioner world, but if you have decided to forego your traditional reimbursement models, you might not need certified health IT because it's only required for reimbursement from CMS. So it doesn't, and sometimes the payment for a certified health IT program doesn't work itself out. You might have found a cheaper non-certified program and you just decide to forego the payment that you might be eligible for in those alternative payment models. But we highly recommend it because what it means is it's not going to guarantee you that you have the best possible system ever, but it is going to guarantee that all the things that we think are important and all of the things you're going to be required to report on from a regulation standpoint, those things are embedded in the system. And they've had to attest to that, and we've tested it. So that's just a note about certified health IT. I wanted you guys to be aware when you saw that, or maybe when a vendor said we're certified, this is what it means, and you can certainly read a little more about it if you want to through that link. So now I'm going to spend the last couple of slides talking about some resources that ONC has put together to help you as you're looking at systems, either trying to put a new one in or trying to figure out maybe how to replace the one you have or to make it better. So the next slide, and this one we're not going to go out to the web for. I just want you to be aware that it's here. What we found through complaints back into ONC is that folks are really on the hook for things in their contract that they did not realize they were on the hook for. A really common complaint is, we're changing our system, and oh my gosh, my vendor wants X dollars to give me my data. Well, if you sign the contract that really only allowed you to own your notes, but you don't own those other data, the lab data, anything that came outside of a progress note, you're going to have to pay for it. And lots of times you agreed to that when you signed the contract. There are a whole host of things that are really common pitfalls, and so our policy team, our really amazing team of lawyers, got together and put this EHR Contracts Untangled piece together. It is not super long, which is nice because most of our stuff is 100 pages or more, and it really gives you the chance to read it and then understand what you're talking about when you go negotiate that contract with a vendor. If you're already into a contract with a vendor, this is a good way to go back and maybe revisit your contract just so you understand what would happen if you decided to change to a new system. You'll know what to expect ahead of time instead of kind of hitting those things head on. So I see that we flipped out to the web here. You can see there are really 9 basic sections. It is a total of 53 pages, and I know that may seem daunting, but it's actually a pretty easy read. And it's well worth your time if this is something that you're going to own. Okay, and actually the second thing I was going to talk about is the Health IT Playbook, and we don't have to go back to the slide deck. If you just want to click on the second tab, we can talk about the playbook right here from the web. There we go. Okay, so this is our Health IT Playbook. I highly recommend this for you guys as a resource. We have packed every bit of really good information that we could in here. The clinical team at ONC vetted the information, every bit of it, before we put it in. You will find that there are some areas that are really lean. So the pediatrics content is really light. The rural healthcare content is really light, and some of it is a little bit old, but it's the best that we could find out there. I will also say that if you have content you'd like to have added in here, let me know. I'll get it vetted and I will get it out there. Most of this is not stuff that ONC actually put together, like the contract guide. This is stuff that we went out and scoured the universe of Health IT to try to get the best of stuff to put in one place so that you didn't have to hop all over looking. So if you guys are going to go out and search the playbook, there are a couple of key points. There's a guide to using the playbook, which I'm getting ready to walk you through how to use it. And there's also an introduction, which is a little video. And we're going to do today, I just want to show you a couple of things under the electronic health records section. We're not going to get into all that other craziness because this is all just the part one. There you go. So if we click on that section, what you guys will see, there we go, when it pops up, is our section 1. We tried to make it as easy to read and follow as we could. So this is the very basic starting point. And you will see that probably a lot of these kind of mirror, especially in the first couple of sections, the stuff that I've talked about, but in much more detail. So we started it with, which phase are you in? So if you're just planning, you would click on planning, and then magically it would take you to the section where we talk about how to plan and select an EHR. We do this in a couple of ways. We have text for you to read, so right off the bat, so you can look through and see if this really applies to what you want or not. This is kind of the best of what we found. We also have PowerPoint options. We have some videos that you can watch. When I talked about workflow and how important it was to do workflow well, we have a section on that. We can talk about how you can read. So here you'll see a PDF, and the next one is a PowerPoint. So different kinds of ways for you to see things, and you can download those and use them at your leisure. So any of the stuff that I talked about today, even interfaces, you could read all about interfaces on here. We have some matrices, so the matrices like the vendor comparison tool, that's a little thing you can print out so you can use it as a template for comparing one vendor to the next. This is the basic beginning part of how to manage your selection, optimization, or replacement of an EHR. I highly recommend that you guys, if you have a minute, to go out here and play in this section. You will also see on the left-hand side, those represent all of the blue boxes from the beginning. So if there's something else that is particularly pressing for you, you can go under that section and look. But really, this is more about today just how to select, how to optimize. And then we do have a section on migrating your data. This is important. As I said, some folks don't realize when it's time to move to a new system that they don't necessarily own all of their own data, so you're going to have to pay for that. You also want to think about which data do you need to migrate, how much. So if you've had a system for 10 years and you have 10 years worth of historical data, how much do you need? Can you put 2 years into the new system and archive off 8 years to somewhere else? You're going to want to be able to make those kinds of decisions that might minimize the output of cache, and also how much historical data do you really need access to in your live system at any given time. So those are all considerations, but those are the first 4 sections of the playbook. And as I said, I recommend that you guys go take a look at it. We worked really hard on it. We've already updated it. We have another big upgrade coming in a couple of months with new content. And we do try to keep, we have some disclaimers on there. You will find some things pointing to meaningful use. And we're moving, obviously, towards a new world of macro. But we kept some of these things because the content was really, really good. So we just put disclaimers on those that said kind of, hey, I know we talk about meaningful use stage 1 or 2, and that's off the books now, but the content is still really good. We just framed it under meaningful use when we created it. So be aware of that. And if we go back to the slide deck, the very last slide, the questions slide, has my email. And we're going to open up to Q&A now. I hope you guys have lots of good, awesome questions. And if for some reason we have too many questions and we don't get to all of them, please send me an email and lay out your question, and I will write you back. I'll warn you now that I tend to write 5,000 words, so I'll try to be brief. But lots of times we finish up and there are lingering questions, and no one ever sends me email, and it makes me really sad and lonely. So send me a note, and with that, I will turn it back over to the presenters and you guys for questions.
Thank you, Rebecca. It's really great information. I really appreciate you sharing your wealth of knowledge with us today. So just a reminder to everyone that you can submit your questions through the question panel on the GoToWebinar control panel. You can also raise your hand if you'd like to ask a question. One question that did come up early on in the presentation was some discussion around incident to billing and whether or not there was something within NP rules and regs about, you know, the allowability of incident to, or maybe, I mean, I can speak to that part, but did you want to just talk kind of in general about the concept of incident to and how that works?
Sure. Yes, and I know Cheryl can give you the details because there are certain things that will then make that not allowable. So, and Cheryl can speak to, I think if you see a patient for a new problem versus an existing problem, I think that kicks that out. So there are definitely some guidelines for when you can do it and when you can't. But the problem is, I talked about the internal research we did that showed that nurse practitioners were much more likely to get Medicaid incentive payments when they use technical assistance. But trying to find data on the health IT use and billing and who got incentive payments, the numbers just didn't make sense to me. When the numbers came back, I was like, I am so sure there are more nurse practitioners doing this than the numbers that I have based on the billing data and the incentive payments. And when we really started digging, I thought, oh, I bet it's because of the incident to billing. So if you have a state where a nurse practitioner is paid at 85 or 90% of what the physician would be paid for the exact same billing codes, of course the practice is going to bill under the physician's moniker if they can, because they want 100% of the billing. That's good for everybody, except it's not good for the nurse practitioners who did the bulk of the work, and I can't find them in the data because when I go to CMS or and I ask for the Medicaid data, I get back data that are tied to that physician's billing information, not the nurse practitioner, because you kind of lose the nurse practitioner in the data. So really what it's about is, as long as you don't, you know, get outside of the rules, there are certain things you guys do as part of the patient workup and the patient visit that are allowed to kind of be, quote unquote, owned by the provider. They add a little bit, they put their name on it, and they bill it out under their name. And it's really a maximizing of reimbursement kind of thing for what it's worth. I had a much easier time finding nurse practitioners in the data in the states where the reimbursement discrepancy was not so large. So that's my general talk. And Cheryl, you certainly could fill them in on all the specifics of when you can and cannot utilize that.
Thanks. So just to talk a little bit about incident to billing, typically it's in the world of Medicare, and it has everything to do with initiation of care. So if you are the initiating provider of care, then the rest of the care that is given by anyone within your practice, since you are the initiator of care, then the billing would end up defaulting to you. One of the things that I would say about billing in general, and that I find very frustrating with us and as nurse practitioners, and I've been a nurse practitioner for almost 30 years, is that the billing piece of the work that we do is often invisible to us in a practice setting. So I don't think I became aware of any issues around billing until I'd already been in practice for quite some time. My suggestion to all of you that are on the webinar today that are nurse practitioners is to talk with your supervisors about how your services are billed for in your particular facility. They may be surprised that you're actually asking that question, but it has everything to do with the reimbursement. Many of the incentives that are coming through with MACRA and MIPS are going to be tied to quality indicators that will be coming from the data that is collected around those quality indicators. And clinicians are going to be bonused on that. So number one, you need to know how you're billed, and you need to know how they're going to integrate you into the bonusing process. Some additional questions that have come up: is there a specific date for the rural health clinics, are required to comply with meaningful use requirements such as MACRA MIPS or face a penalty? When will the penalties begin?
Well, So I will say this for small practices, and really this is, you guys are going to slide kind of under the same issue that small rural health physicians have been complaining about. They want to be exempt, and so they're going to already, I met with the ANA last week, and they gave me some numbers, and it sounded like the large majority of advanced practice RNs are not going to make it in the MACRA requirements anyhow, just because of volume. The numbers are not there, and so you can exempt out. And then they are making even more ways for you to exempt yourself from participating so that you can avoid the penalty. So, and those things are changing. I know you guys have heard there are a lot of, it's funny because on one side we have all of the different types of providers who are excluded from meaningful use, who are really psyched about being part of MACRA. And then on the flip side, you have everybody who was in meaningful use who desperately wants to come out, and so they are clamoring for ways to not participate in this in any way, shape, or form. And I think the way that might play out is you'll see a whole bunch of ways to exclude yourself if you want to, because some people are going to find that there is not a good solid way for them to use this to their benefit, and they will face a penalty, at which point they may choose to just opt out of participating. And I think that'll be an option, especially for small practices. So that's something to keep in mind. And I hear it change, and I hear the conversation changing on that pretty frequently.
True enough. Another question from Sherry, or a question from Sherry. We've purchased a system but are finding it difficult to use. Do you have any resources that we could link to for on-site assistance?
And actually, Rebecca, if you can elaborate, because there are a couple of questions that are coming in, I assume from clinicians that are working in smaller rural practices that don't have on-site support for health IT. So if you can just kind of elaborate on that.
Okay. Yes. And what was Sherry's first? I got focused, my attention span is about 3 seconds. So I got the second part. And what was Sherry's initial question?
Her question is, they've purchased a system, it's difficult to use. Are there any like web assistance or any other services where they could go and get some help on site?
I gotcha. So let's just in general talk about technical support for a minute. If you're already tied in with a vendor, and that vendor is not helping you make it better, the first thing I would do, because it's free, is to find some other, go to your friends. So, and if you're not friends, make friends with some other folks who have that same vendor system in place. You can Google them. You can reach out through, like even here, I don't want to call out a vendor. That would be very bad from an ONC standpoint. But get on an AANP chat board and say, we have vendor X and it is not usable. Who else is using them and what is your experience? Sometimes you will find that other people have already done the heavy lifting of how they fixed certain things and made it more usable. Sometimes you'll find that you might be locked in with a vendor that just has crummy customer service and nobody's happy, in which case you band together and make a lot of noise. There are different ways to go approach a vendor system that you already have in place. Now, if you have the money to pay for it, there are some IT groups who can come in and help you optimize. If you're part of a hospital system or you are tied to any type of system where they have any IT support, I would really stomp my feet and see if you could get them to come help you. Otherwise, there are some places online. I would start with HIMSS. That's H-I, M as in Mary, S-S. HIMSS is really the large overriding health IT community. They all have a state chapter. There's a national chapter. And every city has somebody who's involved with HIMSS, and that covers rural areas as well. So I would find my HIMSS folks and see if there's somebody there that they can recommend or if they can come help you. Your HIMSS chapters are really usually pretty active, and they're very IT savvy. You don't want your typical IT consultant, because those are the folks who come in and fix your phone systems and your servers and things like that. So just for help in general, it really depends on what's broken. But if it's your vendor and your vendor interface and you have 7,000 too many clicks or you have some other issues, you really have to hammer your vendor, and sometimes you can do that better with numbers by finding friends. If it's an individual thing that you need to work on, then I would go through your local HIMSS rep if you can find one, and I can help you with that certainly, to see who's good and who can come in and offer some help with your particular pain point, because they're all different and sometimes they require a different type of specialist. Well, look at that. A link to your local HIMSS chapter right online.
Yes. Yeah, HIMSS is great. We have collaborated with HIMSS as well. Another question, is there a list of vendors that would be well trusted and highly recommended by clients? Is there a way or a place to find that kind of information?
So there is, and I would go back to Google. So if you Google best EHR rural practice, you'll find a couple of things. There's kind of the quintessential class report, KLAS. Sometimes they'll charge you for certain data. Other times you can see, oh, you know, this vendor won best rural practice EHR 3 years in a row or something like that. So the class reports you can go to, as with all data, take them with a grain of salt because it depends on where it came from. I think when you Google, what you'll find is little niche groups where you can then go dig in and see who says what about which vendor. I much prefer finding a kind of a national listserv or a national user group and just pose the question there of like-minded people. Are you guys in a rural setting? Which vendor do you use? Do you love them or hate them, or you're somewhere in the middle, lukewarm? And you will get that great information, and that on-the-ground input is always going to be better than like the Consumer Reports version, because there's no truly independent Switzerland of EHR reviewers. There's always a slant, so your best information is going to come from other people who have put these systems in place.
Thanks, Rebecca. We do have an additional question, but we did want to talk about how to get CEs for today, so I think we're going to forward this final question on data migration to you that you can answer offline. Okay. And we're going to move at this time to our next slide about how you can obtain CE. Joseph from the AANP, my colleague, is joining us today. I turn it over to you, Joseph.
Thanks, Cheryl. Hello, everyone. This is Joseph. I represent the American Association of Nurse Practitioners. There is the opportunity to receive CE credit for today's webinar. There is a very specific list of steps that you would need to follow in order to receive that CE credit. It's all laid out here on this slide that you see. Keep in mind that you can download this entire presentation from the control panel. It's a PDF, so I'd highly recommend that you download the PDF, place it on your desktop so you have access to this particular slide, because this slide is crucial to follow when trying to claim your CE credit. For individuals who registered for this particular webinar from this morning on up until the webinar, there may be a bit of a delay in your ability to receive CE credit, but anybody who registered from yesterday all the way up until the first promotion of this webinar should be okay with respect to being able to access CE credit. But essentially the steps are, you go to the AANP CE Center, there's a link included. You want to sign into the CE Center. If you do not have an account with AANP, you can create a free one. So it's a free registration process, but be sure you use the same email that you used to register for the webinar. Use that same email to register for your My AANP account. Once you're logged in, there is a products tab, and there's a My Account tab, and under that My Account tab, there's a products title you can click on, and under products, you should have listed this webinar, EHR Implementation for Small and Rural Primary Care Practices. And so what you would do is you would click on that, and you could go to steps to receive credit. And the next slide is pretty important. But here, this is what it looks like on the My AA&P side. Once you log in or once you create your free account, you go to the My Account tab and you click on My Products. The product listed there will say EHR implementation for small and rural primary care practices. The one that's listed there is just an example. But so that comes up, and then you want to click on steps to receive credits, and then there is a little code you have to enter, and for that code, it is AANP all caps 2694. That is the code you need to enter in order to access the evaluation. So make sure you enter that, you click submit, and then an evaluation will appear. There is no post-test required for this particular webinar. There is about an 8-question evaluation that will be required. Once you complete the evaluation, you'll receive CE credit. And so if you have any questions regarding this particular process, I'll enter my email into the chat box so you guys can contact me directly with respect to any questions or issues you have with receiving CE credit.
Great. Thank you, Joseph, very much. We appreciate all the work you do in allowing us to be able to get CE credit for this. If there are any additional questions, if you want to know more about TCPI or the work of the Nurse Practitioner Support and Alignment Network, I would encourage you to go to the web address listed on the very bottom of this slide here. It will give you a quick overview of the work. And there is my information as well as Tiffany's. Should you have any specific questions about this presentation or anything else, feel free to reach out to us. We do run these lunch and learns every month, sometimes 2 a month. And in August, we will be doing our next one on culturally sensitive care for the LGBTQI community by Jessica Landry. I want to again thank our presenter today, Rebecca, for her excellent work and presentation. We have a couple final questions we didn't get to, which we will forward to her on your behalf. And please join us next month for our next Lunch and Learn, and thank you again for your participation.
Thank you, guys.